been successfully logged on, there's some instructions for you if you haven't. Does anybody have any problems? Okay, good. These are the instructions. This is a test question. What city hosts RSNA 2013? Chicago, Peoria, Oak Brook, or Lombard. Looks like most people are, nobody's testing the system here by trying to get the incorrect answer. All right. So it looks like we're in working order here. That was excuse me, a text question. We also have touch questions. So what you're going to see is a series of options, one of which will be the correct answer, which you have to double click on to record your answer. And then don't forget to hit the submit button up top in green. These are the standard formatted introductory slides, and I'm not sure if this is supposed to be a question or not. It looks like it is. I'm not sure what the question is, but you're supposed to double click and touch to record your answer on one of these. I'm not sure what doesn't give you a question in this particular instance, but just double click on one of these images to record an answer, and then hit submit. Okay. Most people seem to have answered. I assume the question is which one is Rankin, but I don't actually see the question. Yeah, so this was the correct answer, whatever the question happened to be. Okay, so now that we're all oriented to how this system works, let's get started with the first presentation. I'm going to talk to you today about the differential diagnosis of liver lesions. My name is Chris Roth, and I'm from Thomas Jefferson in Philadelphia. My disclosures. So given the vastness of this topic and the relatively limited time I have, and the fact that we're doing this in an interactive fashion, I'm going to aspire to just show you some of the cardinal features of typical imaging, of typical liver lesions, and give you a simple, common sense, algorithmic approach to liver lesion differential diagnosis. And also help understand the utility of the various pulse sequences and contrast agents in liver lesion assessment. I stratify liver lesions into either solid or cystic etiologies. And within the solid category, hypervascular versus hypovascular. So hypervascular lesions enhance more than liver, hypovascular less, and cystic not at all. In terms of which post-contrast phase each type of lesion is most conspicuous, hypervascular most conspicuous on arterial phase as hyperintense, hypovascular on the portal phase as hypointense to liver, and cystic lesions are fairly conspicuous in all, but maximally when the liver is enhancing at the most, which is in the portal phase. In terms of T2 signal intensity, solid lesions, whether hyper or hypovascular, tend to be mildly hyperintense to isointense, reflecting their bound water content, whereas cystic lesions are extremely hyperintense, reflecting their free water content. Etiologically, hypervascular lesions are usually benign in the normal non-cirrhotic livers, whereas in the cirrhotic liver, we have to worry about the prevalence of HCC. In the hypovascular liver, or in the case of hypovascular lesions, they're usually malignant because of the prevalence of hypovascular metastases, and cystic lesions are almost always benign. In discussing hypervascular versus hypovascular liver lesions and lesion vascularity, it's important to consider the blood supply of the normal liver. So remember that the liver is supplied normally by the portal venous system in 75 to 80% of hepatic vasculature is through the portal venous system. whereas neoplasms are always supplied by the systemic arterial system. So when we talk about lesion vascularity, we're talking about how much arterial supply does it get. So hypervascular lesions have an abundance of arterial supply, so they appear hypervascular compared to liver on arterial phase, whereas lesions that lack an abundance of arterial supply will be conspicuous on the portal phase images as hypointense, while the liver during the portal phase enhances maximally. And this figure represents what I just discussed, where the hypervascular liver lesions are maximally intense on the arterial phase against the relatively hypointense non-enhancing liver, whereas the hypovascular lesions are very hypointense compared to the maximally enhancing liver parenchyma on the portal phase. Which brings us to our first question. Which of the following pre-contrast arterial phase and portal phase image sets shows a hypovascular liver lesion? So this is a touch question. Double-click on the correct answer, or whatever answer you choose to select, and then hit the green submit button. So we have pre-contrast arterial phase and portal phase images. And we're looking for the hypovascular lesion. All right, a few holdouts. Give you a couple more seconds. All right. Most people got this right. Just to sort of a point of how, operationally, don't select. I just put this B here for your benefit to stratify the different lesions, but actually you just touch the. I think this still came out correct, but in any event. So we have most people got this right. These lesions are hypervascular. You can see the arterial phase; they're all very hyperintense, and whereas this lesion is very hypointense, especially on the portal phase image, is typical of a hypovascular liver lesion. So these are the various lesions I just showed. The correct answer was this one, which is an intrahepatic cholangiocarcinoma, which we'll hear about more in a subsequent lecture. This slide shows the spectrum of hypo and hypovascular lesions, and just note that in the case of hypervascular lesions, you have a prevalence of these benign lesions, hemangioma, focal nodular hyperplasia, hepatic adenoma, whereas in the hypovascular category, the prevalence of hypovascular Mets makes hypovascular lesions much more concerning for malignancy, whereas in the hypervascular category, you have a relative prevalence of benign lesions. So in discussing lesion vascularity, contrast agents deserve a little bit of attention because our diagnostic differential scheme involves enhancement, hypervascular versus hypovascular, and differentiating solid from cystic lesions. And we have basically a choice of two types of agents, extracellular versus combination agents. Whereas both are useful for vascularity assessment, the extracellular agents tend to be more robust. They tend to demonstrate more robust enhancement, whereas the combination agents also have utility in the fact that they, up to 20 minutes later, will take up with their hepatic metabolism, will take up the contrast agent, and we can use them to isolate non-hepatocytic lesions, like this example showing in this case of extensive metastases. But I would add that in cases of liver dysfunction, it's not very useful where you don't get a very homogeneous or very robust uptake of the contrast agent. It's not as useful. And at Jefferson, we stopped using these agents with a bilirubin above 2.8. And also, I would say, just remember that the delayed hepatobiliary phase or hepatocyte phase is not incorporated in the ACR-LIRAD scheme for probability of HCC. This is the spectrum of contrast agents used in MRI, but in the context of focal liver lesions, we're really just discussing the extracellular agents and the combination agents. So our next question is, what percentage of patients with GFRs above 30 experience nephrogenic systemic fibrosis after intravenous administration of gadolinium? Is it A, 1%, B, 0.2%, C, 0.01%, D, there has been only one published report, or E, there have only been 5 published reports? I will say this is probably one of the more difficult questions, but I think it's important because I think there's a little bit, well, I won't say any more until we see the answers. All right, good. It seems to be working well. We have almost total, everybody's almost fully responded, so let's see how we did. Okay, so a third of you got that right. Actually, the correct answer was there has been only one published report, but I see we were mostly in the range of, close to the correct answer. So there has been only one published report of NSF in a patient with a GFR over 30. So for that reason, a GFR of 30 is a realistic cutoff point for gadolinium administration. And just remember that dialysis is not an adequate preventive measure to prevent NSF. In evaluating solid lesions, don't forget to assess the background liver. When you have a normal liver, you're often dealing with benign lesions. There's a minimal chance of HCC. Whereas in chronic liver disease, of course, you have to consider the risk of HCC and or cholangiocarcinoma. In normal liver, of course, you have to consider the possibility of metastases in a patient with primary malignancy. But actually, in chronic liver disease, metastases are less common. And in normal liver, hepatobiliary phase imaging is useful, whereas in chronic liver disease, it's often not because of liver dysfunction. So remember clinical factors, whether or not you're dealing with normal liver versus cirrhosis and the risk of HCC, whether there's a primary malignancy or not. And then in terms of imaging features, we look for solid versus cystic nature. And then in the solid category, we're assessing enhancement characteristics, hypo versus hypervascular. Which brings us to our next question. Which of the following hypervascular enhancement patterns is most typical of a malignant etiology? A, early and persistent enhancement. B, early enhancement fading to isointensity. C, early enhancement with washout. Or D, hypervascular lesions are never malignant. It looks like most people know the answer to this question. All right, let's see how we did. Yes, so most people got this right. Early enhancement with washout, which is key. And I'll explain why. This diagram explains kind of a very simple approach to hypervascular lesions. So when you have an early enhancing lesion like this in the arterial phase, you basically have 3 choices. Does a lesion remain persistently hyperintense, in which case it's going to be a flash-filling hemangioma? Does it fade to isointensity with liver, in which case it's either an FNH or an adenoma? Or does it wash out and become hypointense to liver, in which case it's probably an HCC or hypervascular met? This scheme works most of the time, and it's very simple, and it's the reason why hypervascular lesions are in general much easier to stratify and characterize than hypovascular lesions, which don't have as easy of a differential diagnostic scheme. Next question, what is the most likely diagnosis in this case? So you're seeing a pre-arterial portal delayed phase and then a T2, a moderately T2-weighted fat suppressed sequence. The options are A, hepatocellular carcinoma, B, hepatocellular adenoma, C, focal nodular hyperplasia, and D, hemangioma. All right, a few more seconds. Almost unanimous response, 9 holdouts. All right, let's see the results. Yeah, so most people got this right, that's good. Focal nodular hyperplasia was the correct answer. So this lesion exhibits all the typical cardinal features or classic features of focal nodular hyperplasia. The hypervascularity on the arterial phase, you can even see these radiating fibrous septa. It fades on delayed images, and it has this T2 hyperintense delayed enhancing scar. Focal nodular hyperplasia is the second most common benign liver lesion after hemangioma, affecting up to 5% of the population, and it represents a hyperplastic response to an underlying vascular malformation. It will typically demonstrate this avid arterial enhancement and then fading to isointensity on delayed images. In up to 50% of cases, it'll show that those classic features that I showed on the last case with the delayed enhancing T2 hyperintense scar, but unfortunately, at least half of those lesions will not show that those classic findings. Fortunately, FNH does have non-communicating biliary ductules at the parenchymal fibrous interface of the lesion, which allows us to use delayed hepatobiliary phase imaging to improve our diagnostic accuracy. Because the fact that these lesions will take up, remember they contain hepatocytes, they'll take up the combination agents, and so in the delayed hepatobiliary phase they'll become hyperintense and they can't excrete. So they'll remain hyperintense generally in the delayed hepatobiliary phase. And there has been research that substantiates that. Bringing us to our next question. Which of the following hepatobiliary phase images is most specific for focal nodular hyperplasia? Another touch question, so just double click on the answer you want to submit, hit the green bar to submit. You have 5 options, they're all separate cases. And I wonder if those of you using iPhones or smartphones might find this a little bit more challenging. I've noticed that you can drag the images, but if you double click it, you can submit. So you can move it around and then just double click to submit. But it is a little bit easier on a tablet with a bigger screen. And you don't have to actually touch the lesion, just touch anywhere in the image. All right? Give you 10 more seconds. All right, results. Most people got this right, or at least a significant proportion. The correct answer was this one, which is an FNH. And I think you can actually see the fibrous capsule surrounding it, and it has this sort of serpiginous texture, which reflects the nodular fibrous hyperplasia and the intervening septa, which is kind of a typical pattern on the delayed hepatobiliary phase. Notice the non-hepatocyte lesions are all hypointense against the very hyperintense liver parenchyma that you usually see on these delayed hepatocyte phase images. So focal nodular hyperplasia is usually iso to hyperintense on delayed hepatobiliary phase images. One of the chief differential diagnostic considerations, however, would be a well-differentiated HCC. So on the right-hand side, you see this mildly heterogeneously hypervascular lesion on the arterial phase images, which on the delayed hepatobiliary phase images is quite hyperintense in a case of a well-differentiated HCC. However, MRI affords us a multiplicity of different pulse sequences, and in this case, the ADC map shows the restricted diffusion because of the hypercellularity of the HCC, which, to differentiate it from FNH, would not be expected to be bright on diffusion weight images or diffusion restricting and dark on the ADC map. Hepatocellular adenoma is another potential confounder with FNH. It represents a cluster of hepatocytes lacking the normal liver architecture. It lacks a biliary system, and therefore it tends to be hypointense on the delayed hepatobiliary phase images. Of course, it does enhance like an FNH typically, very hypervascular, and then fades to isointensity. But one of the discriminating features is that it usually is a little bit more complicated in its signal characteristics, either by fat, as in this case with the little bit of microscopic fat on the out-of-phase image, or hemorrhage. And this example shows a hepatocellular adenoma with extensive hemorrhage. So you see a lot of T1 hyperintensity, T1 and T2 hypointensity, so probably a combination of methemoglobin and deoxyhemoglobin in a hepatic adenoma that probably recently bled. There's probably a little bit of enhancement along the ventral margin of this lesion, but it's mostly blood. So to reiterate, hypervascular lesions, this is the arterial phase, they're all avidly enhancing. Look to the portal phase, delayed phases, and if it fades to isointensity or it remains persistently hyperintense, it's benign. If it fades, it's probably an FNH or an adenoma. If it's persistently hyperintense, probably a hemangioma. If it washes out and becomes hypointense, it's malignant, most likely, HCC or hypervascular metastases. Our next question, what is the most likely diagnosis in this question, or in this case? And note that your devices will probably not show the images. You'll have to look at this screen, but you will have the obviously you'll see the choices, which are A, intrahepatic cholangiocarcinoma, B, ocular melanoma metastasis, C, hepatocellular carcinoma, D, amoebic abscess, or E, focal nodular hyperplasia. All right. 17 holdouts. 10 more seconds. Okay, let's see the results. So most people got this right. That's good. It was a hypervascular lesion, and this diagram shows why it's most likely being HCC. So it has mild hyperintensity on the T2 weighted image, corresponding T1 hypointensity because of its bound water content. Probably didn't show you enough to know whether or not it was a cirrhotic liver, which of course would elevate your suspicion of HCC. It was clear it was hypervascular, a little bit heterogeneously so. I didn't show it with the vascular invasion, which is what this is supposed to be indicating. And it washed out and had a delayed enhancing capsule in the delayed images. So HCC, usually seen in the setting of chronic liver disease, hepatitis B and C, alcoholic liver disease, 3 growth patterns, solitary, multifocal, and infiltrative. Hypervascular, as this example shows, may be complicated microscopic fat, as you see in the atophase image here, potentially hemorrhage, washes out and has a delayed enhancing capsule. And here's some other features of HCC that might complicate the more typical appearance, but here's on the T1 fat suppressed image, there's a little bit of there's a lot of hyperintensity actually. It gets brighter in the arterial phase, probably enhancing, and the subtraction corroborates that. It's definitely arterially enhancing. Here's an infiltrative amorphous appearing lesion with tumor extending into the portal vein. You can see that it's probably enhancing in the case of tumor thrombus. Compare that to this where there's probably bland thrombus in these 2 infiltrative cases of HCC. Next question, all the following liver lesions are typically hypovascular except A, intrahepatic cholangiocarcinoma metastatic neuroendocrine tumor, C, gastric adenocarcinoma metastases, D, confluent hepatic fibrosis, or E, hepatic lymphoma. Sorry, I'm probably going to be rushing a little bit more now. The diagnosis live gaming aspect of this definitely adds a little bit of time compared to what I'm used to conducting in a non-interactive style of presentation. All right, most people have answered. Looks like most people know the answer to this one. 5 more seconds. All right, almost everybody got that one right. That is correct. Metastatic neuroendocrine tumor is the one that is not hypovascular. And this is an example. So you see these large, mild, again, the bound water makes them mildly hyperintense on T2 weighted images, and then you can see the heterogeneous hypervascularity, hypervascular metastasis. These are the common hypervascular metastases. Generally, Mets in general will show this ring enhancement. It's more prominent in the arterial phase on the hypervascular lesions. This is what I'm talking about in the case of a renal cell carcinoma exhibiting this ring enhancement. This is a case of ocular melanoma metastases with a melanotic content, this T1 hyperintensity. Moving on to hypovascular lesions. which are more often malignant because of the preponderance of hypovascular metastases. And the benign lesions are pretty uncommon. And just to remind you, they're most conspicuous on the portal phase image as being hypointense to liver. Our next question, what is the most likely diagnosis in this case? So you're seeing a moderately T2-weighted image, arterial phase, and then a delayed phase image, post-contrast. A, giant hemangioma. B, hepatocellular carcinoma. C, focal nodular hyperplasia. D, intrahepatic cholangiocarcinoma. Or E, hepatocellular adenoma. All right, so again, looks like people are pretty much on the mark. 10 more seconds. 11 holdouts. All right, let's see the results. Yeah, most people, 2/3 got that right, 67%. So that was an example of a intrahepatic cholangiocarcinoma. This is another example showing the characteristic peripheral T2 hyperintensity, the cellular component, the central fibrous or desmoplastic component, which is usually responsible for this capsular retraction you see here in the coronal image. And they tend to have this centripetal sort of enhancement pattern from early to delayed phase in the case of peripheral cholangiocarcinoma. So I'm not going to talk, in the interest of time, and because we're going to hear more about this in a subsequent lecture, I will just say that in terms of location, there's 3 types: the peripheral or intrahepatic, which is what I'm going to restrict myself to talking to, the hilar or Klatskin, and then the extrahepatic forms. And they follow 3 growth patterns: the mass forming, the intraductal polypoid, and the periductal infiltrating types. So this is the kind that is the mass forming is most characteristically intrahepatic. Our next question, which of the following is usually not hypovascular? A, pancreatic adenocarcinoma metastases, carcinoid metastases, gastric adenocarcinoma metastases, or colorectal metastases. I might have made my questions a little bit too easy. I gave an earlier version of this lecture to the residents, and they told me it was too hard. So I think I probably should have stuck with my original version, because it looks like we're going to have about at least a 90% correct rate on this particular question. All right, 5 more seconds. Yeah, 93% correct. Carcinoid was the correct answer. And these are carcinoid mets, these hypervascular lesions. And these other metastases are typically hypovascular. Hypovascular metastases are the most common malignancy, the non-cirrhotic liver, with colorectal being the most common primary. And are generally, we're differentiating from cholangiocarcinoma and other rare and unusual hypovascular lesions. And here you can see, I just want to underscore the importance of using the diffusion-weighted images, which tend to have extreme contrast for metastases. And here's the ADC map confirming the restricted diffusion, highlighting the hypercellularity of these lesions. Our next question, this hypovascular lesion is associated with which of the following? A, chemoembolization. B, liver flukes. C, hepatolithiasis. D, primary sclerosing cholangitis. Or E, entamoeba histolytica. Somehow the space got removed between the entamoeba and the histolytica. So we have a STIR image on the left and a T2 image, second from the left, and then an out-of-phase image and an arterial phase image on the right. Yeah, I figured that this was probably going to be the most difficult question. There's a key finding here that I think helps you determine what the correct answer is. But it's sort of a multi-part. Got to make all the findings and then deduce what the risk factors might be. All right, 10 more seconds. Okay. All right, so almost a third of the people got that right. That was a little bit more difficult. That case was an example of a liver infarct. And what I was referring to is the fact that there's a portal vein thrombus here, and then you have this wedge-shaped peripheral subcapsular lesion. It's a fairly common appearance of a liver infarct. This other example shows an HCC pre-embolization. Post-embolization, you have this infarcted lesion with a little bit of tissue infarction next to it, a more globular pattern. So it doesn't have to be wedge-shaped like this, but an uncommon lesion, but in the hypovascular differential. So hypovascular lesions, to reiterate, are usually malignant because of the preponderance of metastases and the fairly uncommon nature of these benign lesions. And they're most conspicuous on portal phase imaging. And just for completeness, I showed an example of lymphoma. Generally has this monotonous, mild T2 hyperintensity. It's enhances mildly and is generally hypovascular. Moving on to cystic lesions, I stratify them into developmental, inflammatory, neoplastic etiologies. Here you see a case of polycystic liver disease. And you can see the involvement of the kidneys. Some of these lesions are complicated by hemorrhage and probably some fibrinous internal debris. So cystic lesions, of course, don't enhance except when they're neoplastic and have solid tumor components. They generally will exhibit free water or fluid signal characteristics. So this is just showing you that a malignant lesion with bound water on a T2-weighted image is fairly inconspicuous compared to the free water and extreme hyperintensity of the fluid-intense lesions. So cystic lesions contain free water, as you can see here on this heavily T2-weighted image with a T, probably in the 180 to 200 range, will not enhance. And we refer to these heavily T2-weighted sequences as a lesion suppression sequence because these lesions with bound water, like an HCC here, are very inconspicuous, especially when you compare it to the ascites around it. Whereas the moderately T2-weighted sequence here with the TE probably in the range of 80 milliseconds is much better at showing these lesions like this metastasis with bound water-bound to macromolecules. Next question, the cluster sign is associated with which of the following lesions? A, metastatic mucinous colon carcinoma, B, hydatid or echinococcal cyst, C, amoebic abscess, D, candidal abscess, or E, pyogenic abscess. So we have a delayed enhanced image here and a T2-weighted, heavily T2-weighted sequence here. This is one of the more difficult questions. So in the interest of time, because I've probably already exceeded my 30 minutes, I'm not going to give you too much time to answer this one. We only have 9 holdouts. The correct answer was E, pyogenic abscess. Yes, so this is showing you the cluster sign, which is a common feature in pyogenic abscess. And this sort of highlights the evolutionary development of a pyogenic abscess. So you have a segment of liver that is inflamed and undergoing early liquefaction. After a day to a week or so, small foci of clustered liquefaction are present, and that's the cluster sign. Eventually, they all coalesce, and you end up with a cystic lesion with internal necrotic debris and a fibrous wall. Which of the following lesions is most typical of an echinococcal cyst? So a touch question. You can touch the picture, the actual images, not the letters. Again, I don't want to slight my colleagues here, so we're going to move along pretty quickly. We're almost to the end here. It's hard to budget in the time for the audience response. 10 more seconds. All right. So the correct answer was this one, B, which showed the typical daughter cyst appearance of a echinococcal cyst. This is actually another pyogenic abscess. Notice this is perilesional edema and enhancement. This is actually a amoebic abscess, and this is a biliary cystadenoma. So the daughter cyst, the classic pathognomonic appearance of a gonococcal cyst. Amoebic abscess showing the internal shaggy wall, which is a classic feature, also has this perilesional edema, which will enhance because of the extracellular nature of inflammatory response. Last question. These three cases are examples of what lesion? A, cholangiocarcinoma. B, pyogenic abscess. C, a echinococal abscess. D, degenerated or fibrosed or sclerosed hemangioma. Or E, biliary cystadenoma. All right, I will give you 15 more seconds. This is a somewhat more difficult question, I can tell. All right, let's see the results. Most people got that right. That's good. That was a biliary cystadenoma. And so toward the end of the talk, it's the last thing I have to talk about is cystic neoplasms. So actually, this case, while it's cystic, it has a lot of septal and enhancement and excrescences that are enhancing. It's probably not a biliary cystadenocarcinoma. This case shows septa and differential signal intensity of the locules, another typical cystadenoma feature. And this case shows the septa and the calcifications, another feature of biliary cystadenomas. So cystic neoplasm is primary or secondary. We saw biliary cystadenomas. I only bring up embryonal sarcoma because it looks cystic, but it's actually myxoid. And then you have cystic variants of primary neoplasms like HCC. And of course you have secondary cystic metastases, either hypervascular that undergo cystic degeneration or mucinous, which can look cystic, like these colon mets. So in summary, our diagnostic algorithm, cystic versus solid. Within the solid category, hypervascular versus hypovascular. Remembering that the liver has portal supply, so a lesion, all neoplasms have arterial supply. If there's enough of it, they'll be hypervascular and hyperintense on the arterial phase. Otherwise, they're hypovascular and appear hypointense on the portal phase. Hypervascular lesions are more often benign because of the prevalence of these benign lesions, FNH, adenoma, and hemangioma. Hypovascular more often malignant because of the preponderance of metastases and the relatively uncommon benign lesions. And cystic lesions, we saw developmental versus inflammatory versus neoplastic. So I want to thank you for your attention. We'll hold off on questions till the end. It's our job to ask you questions in this session. So I want to thank you very much for your attention. Our next speaker will be Dr. Masoom Haider, who's going to discuss pancreatic cystic neoplasms. And I apologize for going over.
All right, well, good morning, everyone. It's a pleasure to be here from University of Toronto, and I've been charged with talking to you about, I think, a difficult problem that we all encounter is really consistent management of pancreatic cystic lesions. I would draw your attention to the website listed here, mybodymri.com, and that's where you can get the guidelines that I'm going to be listing here, and it's going to be really impossible to, in the time remaining, to go through all the scenarios. So just keep that in mind. It's a good reference that you may want to post at your viewing stations. So we face some common problems right now in the management of cystic pancreatic lesions. One is there's no question, and there's been publications on this, that there's variability in radiologist recommendations. The guidelines are still in evolution, so they're not gospel, but there are guidelines. I think this gives us some medical legal comfort in deciding when to stop follow-up. Symptomatic lesions, as a general principle, are much likely to undergo therapy and treatment. So in terms of your recommendations, it's important in the history to know whether the patient is symptomatic or not. And certainly radiology is of most importance in those patients who are asymptomatic. Lesions in the tail of the pancreas are likely to have a lower threshold for surgery because the surgery is somewhat less complex. And there is a general trend towards doing less and less surgery for pancreatic cystic lesions and more surveillance. And there's an expanding role of endoscopic ultrasound. And I would say this has been a definite evolution in the management just in the last 5 years, where we've seen movement in all of these directions. So the radiologic approach should be to classify the lesion into subtypes based on imaging features, follow the guidelines, and individualize treatment based on the specific patient. So it's very much an interaction between radiology and the surgical specialty. I'm not going to go through the salient features and the distinguishing features of all the cystic lesions. That's textbook stuff. But certainly the key ones you need to know are IPMN, serous cystadenoma, mucinous cystic neoplasm, or MCN, and then you have an unable to classify category, often the simple unilocular cyst. And there are other rare lesions, and I'll touch on those. Certainly for IPMN, the detection of main duct involvement is key. So starting with our first question, and I'll ask you to try and answer these in about 30 seconds if possible. Here we have two cases, both similar. See if I can get the animation to work on this one. Yeah. And I'd like you to decide on what the next step is. What would you recommend in seeing these lesions? They're both T2 weighted images, one sagittal at the top, the other axial at the bottom through the pancreas. They're heavily T2 weighted. So no further follow-up. Follow-up in 6 months, follow-up in 12 months, follow-up in greater than 12 months, endoscopic ultrasound or surgery. It's good. We're getting some good responses in. Okay, so I'm going to go and show the results here. And so follow-up in 12 months fits with the current guidelines and is a correct answer. I think there's some leeway in the answers, and I will go into that a little bit. I'll point out that Dr. Roth is from Jefferson and Philly, and Dr. Javeri and myself are from Toronto. We'd like to see the Maple Leafs win for once, so hope you guys can get a few more of these right. So international consensus guidelines were published in Pancreatology in 2012. So this is a reference specifically for IPMN and MCN. So introductory papillary mucinous neoplasm and mucinous cystic neoplasm. And I'm going to refer to these guidelines in discussing the management for this. So what you'll notice here at the top is you're looking for either obstructive jaundice, so symptoms, enhancing solid components, or main duct involvement greater than 10 millimeters. So these are the three key clinical and imaging features that are going to decide whether the patient goes straight to surgery here or not. So in this case, we didn't have symptoms, very small lesion, no main duct involvement, so no surgery, any of the following features. So the next one is a cyst greater than 3 millimeters, thickening or enhancing cyst walls, main duct size 5 to 9 millimeters. So when the main duct gets over 5 millimeters for an IPMN diagnosis, this is where we're going to think about this as an option. And as we come down further, we say no. So what is this? We get all the way down to size. So the next tier for this small side branch IPMN morphology is to say what's the size. In this case, it's less than a centimeter. So this would say CT and MR in 2 to 3 years for this patient. And so the best answer here is follow-up in greater than 12 months following these particular guidelines. There's another set of guidelines which would say follow-up in 1 year. So it depends which two guidelines you want to follow. So if you were in the group that answered follow-up in greater than 12 months, that's also acceptable for this response. So salient features again, side branch lobulated lesion connected to the main duct in both cases. Now, it's important to understand the pathology of IPMN, and that in fact what we see is a spectrum of pancreatic intraepithelial neoplasia leading to invasive carcinoma. And so there's a spectrum of disease at pathology, and the way the pathologist interprets and classifies this disease is actually important in terms of the use of the word carcinoma and invasion. And I can't get into more details than that, but in terms of deciding which patients have invasive and non-invasive disease on pathology, it's important that, again, within your group in the hospital, including the pathologist, that there's clear understanding of these terms, and this is gone through in the guidelines. So just to reiterate and emphasize, because I went through that pretty quickly, it's really the main duct or combined main duct and side branch IPMNs that need some sort of closer surveillance or action, particularly if the main duct is 10 millimeters or greater. And so it is the main duct and then in particular solid components that are key to the decision for aggressive management. So let's look at this case here. We have a lobulated lesion in the tail of the pancreas post-contrast. The central portion is enhancing. It's over 3 centimeters in size. And as we go through this, you can certainly see that the main duct is dilated, and it's dilated at about 10 millimeters. So this has all of the aggressive features. At surgery, this patient did go to surgery. It was a non-invasive carcinoma, but had papillary and with papillary components. So at this point, it had not gone to full invasion. So that's a mixed and main and side branch IPMN. Let's see, we can go to the next slide here. And so that has all the high-risk features, and according to those guidelines, would go straight to, it says, consider surgery if clinically appropriate. If this was a 75-year-old patient with congestive heart failure, may have done fine with follow-up. Another case, 70-year-old male. Here we see a lobulated lesion with both downstream dilation. This is probably just at the borderline of 5 millimeters, upstream dilation. And really here the management hinges on whether you're convinced whether there's an enhancement internally or not. We were convinced that there was enhancement, but you can see as you go through the guidelines here that if you were convinced there was enhancement, the patient would go to surgery, which is what happened in this case. If you weren't convinced that there was enhancement, then the patient would go to endoscopic ultrasound. And what you're going to see is that as these guidelines come out and get more and more entrenched, that endoscopic ultrasound is being used more and more and more as the reference standard for problem solving. Now, if you don't have endoscopic ultrasound and you weren't convinced of the enhancement, you could have ended up close surveillance alternating with MRI and endoscopic ultrasounds. You wouldn't have endoscopic ultrasound. So this means close follow-up MR in 3 to 6 months. So in the worst case scenario, you don't have endoscopic ultrasound, you get a bad exam, you're not sure there's enhancement, you have no good way of further characterizing this. The minimum you're going to end up with these guidelines is a 3 to 6 month follow-up MR. So this patient had moderate dysplasia and no invasion at surgery. Multifocality, very, very common with IPMN, and something that does not indicate more aggressive disease. So a very important point here is that multifocality does not imply more aggressive disease. We can see these dark dots in here. These may be papillary components, or they may be accumulations of more dense mucin. And this patient went on to a distal pancreatectomy, had a positive margin, and there's a reluctance in some cases to go on to total pancreatectomy because of the enzymatic deficiency for digestion, as well as the brittle type 1 diabetes that ensues. So surgeons, again, will sometimes take out just the dominant lesion, and this is an evolving surgical practice. So multifocality in up to 30%. So next question. Here we have a lesion. Remember, classify it first, then decide on management based on your classification. So 36-year-old female, asymptomatic. What's the next step? Follow up in 3 months, follow up in 6 months, follow up in 12 months, endoscopic ultrasound, or surgery. Right. Show the results on that one. So excellent. That's the correct answer. Almost all of you got that right, and because this has the classic features. And just click on the right button here. There we go. So we can see here the importance of, and I just want to show this pre-contrast. We have contents that are T1 bright. And you need to look very carefully, or at least perform subtractions on this, because then when you look at the post-contrast, see how this nodule sort of vanishes into the background. So either do a subtraction in looking at enhancement for the papillary components within the tumor, or look very carefully if you've got a background of T1 bright. The other thing that's characteristic of MCN is to see the clustering along the margin of the cyst. This doesn't occur in all cases, but it's certainly something that is typical of MCN, in addition to female and in the tail of the pancreas. So surgery is the correct answer here. I won't go through the classic features for the sake of time. So another case, and I think a little more challenging, this one, 32-year-old female, asymptomatic. Next steps for this one. So no further follow-up. Follow-up in 6 months, follow-up in 12 months, follow-up in greater than 12 months, endoscopic ultrasound, or surgery. That's good. We got the answers coming in. That's great. Okay, let's have a look. So a fair number of you got that right, surgery. But I would say the group in E is not an unreasonable option either. And I think this is the point here: is it really depends on how confident you are in your classification. So. How do I get to the next slide, Tony? There we go. Okay. So what I want to show you here is that it hinges on whether you feel that these septa are enhancing or not, and the size of this thing is certainly over 3 centimeters. So here I'm going to show you another set of guidelines, and this was published by the ACR. This is also going to be in the downloadable handout. Very, very important set of guidelines. And here we have something that fits into the category of a greater than 3 centimeter cyst. And if you thought this was a serous cystadenoma, which it doesn't really have classic features for, I would say that you should reconsider that interpretation. But you would certainly consider resection when it's greater than or equal to 4 centimeters. This really doesn't have the features of serous cystadenoma, but you might consider it if you didn't make the diagnosis of MCN. In this case, which is what we did, you might consider this an uncharacterized cystic mass or other cystic neoplasm, in which case endoscopic ultrasound and cyst aspiration or resection, depending on comorbidities and risk, would be the appropriate choice. So if you make this an MCN diagnosis, the prior set of guidelines, which was for MCN and IPMN, would say this goes to surgery. If you didn't make the diagnosis, you would be in this category. You wouldn't know it was a non-specific cyst, so you go back to the ACR guidelines, which is for all cystic lesions like this that you can't really classify. And then when you get to this one, you're going to end up with cyst aspiration. So those of you that selected endoscopic ultrasound, this is also correct. So 5 or 6 is correct in this case. So what about endoscopic ultrasound? Well, it's operator dependent. It really has 2 components: morphologic analysis. Can do tissue sampling, but as I showed you that slide of pancreatic intraepithelial neoplasia and evolution, this is not a unifocal evolution occurring in one area of the cystic lesion. It can occur in scattered degrees all over the lesion. So there's a sampling problem with tissue. So it's really morphologic analysis as well as cyst fluid analysis, with the CEA being elevated, indicating the presence of mucin. Not necessarily whether it's malignant or not, but whether there's mucin in it or not. And so there's a lot of active work going on here. I think it's very important to have the discussion with your gastroenterologist, and the level of expertise, and it's operator dependent, is critical to how you use this within your institution. But certainly part of all the guidelines. So we're getting into tougher cases now. Asymptomatic, 2.8 centimeter lesion, elderly female. What would you do next? Follow up in 6 months, follow up in 12 months, follow up in 24 months, endoscopic ultrasound, and surgery. And I'll tell you there's not one right answer here, but we'll go through the guidelines on this one. And it depends a lot on what your interpretation of this lesion is, how you classify it. But what you'll see is the guidelines all get you to reasonable options. Okay, so now a number of you may think you've got this wrong, but you really haven't. So C is certainly the follow-up in 24 months. If you did one classification, is one right answer. But I will tell you, I'll show you, we'll go through this and tell you what our interpretation was. So if you follow the ACR recommendations in their consensus document, this is a 2 to 3 centimeter lesion. And if we've got our MRI, MRCP, if you thought this was an uncharacterized cystic mass, you'd do a yearly follow-up. I didn't really show you enough to determine if this was an IPMN, but this doesn't have the typical look of an IPMN, so we didn't call it that. But certainly, if you did, then you would do follow-up every 6 months for 2 years. If you thought it was a serous cystadenoma, which is what we thought, then this would be follow-up every 2 years. So you'd be in this spectrum depending on how you classified. And so that's because we thought this was a serous cystadenoma, lobulated, more central conglomeration of tissue and small cystic components. That's what we did here. But any of these answers, I think, are reasonable for this particular lesion. This is the patient's follow-up, 2005 to 2009. And there is some literature suggesting that for these lesions, use of gadolinium may not be necessary. I think it's debatable, but you can see, and this is fairly typical for serous cystadenomas, that sometimes one of the oligocystic or one of the cystic components will grow more than the others. And so this patient continues on surveillance as they elected, because of patient factors, not to operate on this patient or do endoscopic ultrasound. But that's a 4-year follow-up right now. The patient's doing well. So for serous cystadenoma, that's really considered resection when they're greater than 4 centimeters or symptomatic. So again, I won't go through this for the sake of time. Okay, so here we have a click diagnosis case, if I can get it up here. So I would like you to click on, and you got to click in the right place here. So it is important where you click. There's 2 images here, and this is a challenging case to clinch the diagnosis. I'd like you to click on the finding that clinches the syndrome for this patient. So please go ahead. And this one I'm going to give you some time on because I think it's a cute case. So we'll get up to a minute. So take your time looking at it. I figured if I went through guidelines the whole time, you'd be bored. So I'll show you at least some good cases. Okay, we've only got still got 30 people, so a little more time. Give it a try, even if you're not sure. All right, so we got a few people who got it right, and you'll see that a number of them have clicked on the spine. So this is a hemangioblastoma in von Hippel-Lindau disease, and just to point out that serous cystadenomas are well described as a feature of von Hippel-Lindau disease, and also pancreatic cysts are one of the commonest features in von Hippel-Lindau disease, people with the gene, and you do not have to have cystic renal lesions to have von Hippel-Lindau disease. So an interesting case. All right, I'm going to finish off with the incidental unilocular pancreatic cyst, this little tiny ditzel that we see on our MRs particularly. And I'm curious as to what your next step would be. And there is an answer that follows some of the guidelines, so but please go ahead and answer quickly for this one, as I'm already 2 minutes over. So. All right, so let's see the results. So a number of you are going to follow up on this in a year, and I think that does follow the current ACR recommendations or their guideline recommendations. So that's the correct answer. I'm glad to see that most of you are not trying to ask an ultrasonographer to do something with this, so that's good. And the Maple Leafs are going to lose. All right. So if you follow this algorithm, less than 2 centimeters, it says it's the ACR1, single follow-up in 1 year, preferably MRI. If it's stable, no further follow-up. And I think this is the thing that we really need from our consensus committees, is when to stop follow-up. First, I think there's a number of people who wouldn't even do any follow-up on these things, and these are sort of the ditzels, as we call them. I think that following for a year is the current recommendation. I think this is controversial. So if you saw this in a 40-year-old female, would you really never do any follow-up in the next 5 years, 10 years? It's going to be stable in a year, almost certainly. And so I think that's where some controversy is. When you look at the lifetime risk, is this a harbinger of something? Should we just completely leave it alone? But certainly you have something to go back on in terms of medical legal issues, in terms of saying 1 year follow-up is adequate. And so the other sort of issue is whether you want to, if you're going to do any follow-up, and if you're really going to, the second issue is whether you really want to substratify lesions in less than 2 centimeters or not. And I think this is where, again, we're going to see some refinement. So remember the IPMN guidelines that I showed you actually stratified follow-up based on whether it was less than 1 centimeter, less 1 to 2 centimeters, or more than 3 centimeters as well. So the size-based stratification, less than 2 centimeters, is something that may come in, may not come in. So certainly, because of the high prevalence of cysts less than 1 centimeter, we'll probably see some refinement in that area. So I think I'm pretty much over. I want to leave you with just one other case to remember that we shouldn't, because of these guidelines, throw out our diagnostic acumen. Remember that cystic degeneration in neuroendocrine tumors, which this is a case of, is a not uncommon occurrence. It's a little under 10% of all neuroendocrine tumors can do this in the pancreas. And so if you see irregular rim enhancement, yes, MCN is in the differential diagnosis, but don't forget one of the commoner variants of a common disease in the pancreas, neuroendocrine tumor. Well, thank you very much, and go Leafs for the third session. Our next speaker is Dr. Kartik Javeri. He's Associate Professor of Radiology at University of Toronto and University Health Network, and he's going to be speaking to us on the difficult topic of cholangiocarcinoma.
Thank you, Dr. Hayter. Here are my disclosures. So I'm essentially going to try and cover cholangio in 30 minutes, so I might have to go a little fast in some sections. I know it's a difficult topic, but just try and stick around. So cholangiocarcinoma is essentially adenocarcinomas, as you all know. They arise from bile duct epithelium, anywhere from the liver, periphery to the ampulla ovata. Because they have a diverse range of growth patterns, locations, and imaging appearances, they provide some significant diagnostic and therapeutic challenges. Even though it accounts for approximately 10 to 15% of primary hepatic malignancies, there is an increasing incidence in the United States since 1985. And there's a lot of relevance of making this diagnosis, particularly in the setting of chronic liver disease from a perspective of a liver transplant eligibility. I'm going to try and divide my talk into kind of 3 parts and try to make it interesting by throwing in some game show questions. So essentially on the diagnostic side, I'm going to try and address some of the issues related to MR protocols. We'll talk about classification and patterns. Dr. Roth earlier touched upon it. I'm going to go into a little more detail on that. We'll talk about some mimics of cholangio, which are quite common, and it's important to know them and recognize them so as not to mistake them for cholangiocarcinoma. And finally, there's a lot of confusion around staging systems. There are a lot of staging systems out there, and which is actually the correct one to use from a resectability point of view, which is essentially why we're imaging these patients. I'll try and kind of clean the air around that. And finally, we'll talk about surveillance of the high-risk groups, which is, again, another complex topic by itself. So overall, it's a very complicated topic. In terms of a protocol for cholangiocarcinoma, it's a standard abdominal protocol which is tailored to assessing the pancreas and biliary tree. So you have your coronal and axial T2 weighted images, you have your gradient echo and post-phase images, and the crux of the protocol really is the MRCP pulse sequences, which are acquired typically in a radial thick slab fashion, but you also want to supplement. Most neuroscanners have the facility to do high-resolution 3D MRCP with high spatial resolutions, which are really key for assessing actually the resectivity of these patients. We also throw in diffusion, and there is a kind of a complementary role. I wouldn't say there's a great role for it, but it kind of helps at times. And finally, you would finish off with some kind of 3D T1 dynamic gradient echo imaging, and you could supplement that with coronal and axial high-res images. So that's your standard pancreas biliary protocol to evaluate these conditions. So here's an example from a protocol perspective. If you consider this as your routine contrast-enhanced axial CT and you're trying to stage the extent of bile duct involvement, you can see it's quite difficult on an axial image. Like you can see this bilobar obstruction, but if I told you which ducts are actually exactly involved, it can take quite a while to accomplish that. However, when you look at high-resolution MRCP pulse sequences, you can trace the segmental biliary anatomy, particularly if you're used to doing this on a regular basis, quite quickly. And as well as if you look at either the MIP projections or the thick slab projections, in just a snapshot, you'll be able to identify what ducts are involved. So in this case, on an axial image, I had difficulty actually telling which ducts are involved. However, on these 3D and radial projections, I can clearly tell the left hepatic duct is involved, the right anterior and right posterior ducts are involved, the confluence is involved, and the proximal portion of the common bile duct is involved. So that makes it really quick to assess the longitudinal extent of the tumor, and we'll talk about that a little later. So in terms of, I don't want to go into too much into detail about the protocol, but this is really a workhorse for MRCP, is your 3D T2 coronal TSE or FSE type pulse sequences. These are known by various names of space for FSE or TSE, depending on the vendor you have. Essentially, they're navigative triggered or rest triggered. They have high spatial resolution. You can go down to a millimeter thin isotropic, and they really have good SNR. You could also manipulate this data set on a workstation, or if your PACS allows this to do so. Unfortunately, I think my PACS just crashed in terms of manipulating the data set to look at the actual site of obstruction and look at the segmental anatomy. You want to superimpose another pulse sequence just in case one of the MRCP pulse sequences failed or was suboptimal, and typically that's a thick slab radial projection. You classically require about 14 or 15 images. They're usually about 10 to 12 degrees apart. And what these kind of pulse sequences do is they give you a very nice snapshot of the biliary tree and the anatomy as I showed earlier on. What about diffusion? What is exactly the role for diffusion? And it's simple for me. It's just detection. So here's a question for you. It's a game question. So if you can try and answer that question. The question here is, where is the tumor? So this is a B150 image. And the question is, where is the tumor? Is it A, centrally? Is it B, right duct, left duct, or not on this image? So go ahead and start answering, please. It's kind of a trick question, and it's just I'm trying to make a point as to what really diffusion can do. So it doesn't matter whether the answer is right or wrong. So we'll just take a look at the results here. And the answer here is centrally, and that's absolutely right. And about half of you got it correctly. And the point I'm trying to make is when you're looking at diffusion-weighted images, it's obviously the high B-value images which actually have an impact. So here you can see suppression of the bile, and you can see a large tumor. But obviously, you didn't really need diffusion to make that call because you're going to see that on a T2-weighted image as well as a post-contrast image. So what was really the role? And I can show you another anecdotal example. This is actually from a paper from Dr. Studi and al., where it's a nice example showing a common problem that we encounter where we have an obstructed bile duct and we don't see a tumor. So really the question is this just ampullary stenosis? Is this a benign stricture, or is there really a small tumor in there? And it's kind of difficult to tell just on the basis of these axial T2-weighted images. However, when you look at the diffusion-weighted images, clearly there is a small lesion which is restricting, and you can easily identify that. So that's probably one of the complementary roles of diffusion, and we added on in our protocol. Another role for diffusion, particularly in the setting of chronic liver disease, I would say is in the characterization of a mass. And it's not uncommon to find cholangiocarcinomas in patients who have chronic liver disease who are being assessed for transplantation. And as Dr. Roth showed earlier in his slides of intrahepatic cholangiocarcinoma, there's a lot of central desmoplastic reaction or fibrosis within a mass, which kind of results in a lower signal intensity on the B-value images and the reverse on the EDC images. So you kind of get a target sign as a marker of intrahepatic cholangiocarcinoma. It's not 100%. There is some overlap with HCC. However, if you do see that, you might want to lean towards an intrahepatic cholangiocarcinoma, particularly when the enhancement pattern is not typical for HCC, and it does matter for transplantation. So that's another role for diffusion-weighted imaging. What about contrast and diffusion-weighted imaging combined? So this is a real-life scenario from my practice where a patient walked into ER for a renal colic and was identified to have this biliary obstruction or soft tissue impaction. There was a cholecystectomy. Patient obviously has polycystic kidney disease. And the question is that a mass or is that just sludge and impacted stone? So as per our protocol, the patient was called back for an ultrasound, and there is biliary obstruction there, and there's a lot of echogenic material within one of those ducts, and it's shadowing, and essentially it looked like stones with biliary obstruction, but there was still concern that there was an underlying mass on that ultrasound. And so we have a group of people who are quite experts at contrast-enhanced ultrasound, and we did a contrast-enhanced ultrasound, and there was no enhancement identified. The concern was still, is there a cholangiocarcinoma in that patient? The patient landed up in MR, and this is what I saw. So we saw obstruction of the left hepatic duct. We saw significant obstruction. We see signal intensity on the diffusion-weighted images, which is actually restricting truly and also has low ADC, suggesting that there is something there other than just stone in there. And furthermore, on contrast, you can see subtle enhancement actually within that area. So MR here is quite diagnostic for a cholangiocarcinoma, which is resulting in biliary stricture and impacted stones, and it's not just stone disease. So MR can make a real difference in terms of characterization of these kind of problems. So once you've diagnosed the cholangiocarcinoma, the next step is try and classify it because it has implications for further management. And commonly, you can there are two pathways you can take, as I said earlier. You could go location, or you could go on growth pattern and morphology, and you can classify them as either ICCs, which are intrahepatic cholangiocarcinomas, or ECCs, which are extrahepatic cholangiocarcinomas. More often, you might want to use the morphological classification, which is the mass-forming periductal infiltrating, or the intraductal type. And the reason for doing that is the actual morphological classification can predict to some extent biological behavior and therefore the prognosis, whereas on the other hand, the anatomical information may just tell you where the location of the tumor is, and it could actually tell you what the risk factors for the tumor were. But the morphological classification actually gives you some biological information, and let's see how. So here's a question for you. So these are proven cases of cholangiocarcinomas, and the question is, which is likely to have a better prognosis based on the growth pattern alone? So we're not talking about the actual staging of the tumor, but just based on the growth pattern, which one of these is likely to have a better prognosis? So you have 3 year, and I think this is a touch question where you have to touch anywhere on one of those 3 images for the answer. So please go ahead and try that. Okay, I'm going to have to need some more stimulation for the audience participation. So we still have about 20 people trying to vote on there. So there are 3 examples here. You just have to click one image in terms of the prognosis. And let's see the results here. And the correct answer is, I think most of you got it right, is the last one, and we'll talk about that in a bit. So here are the 3 types: mass-forming, periductal infiltrating, and intraductal growing, which actually has the best prognosis, and let's see why. So the most common type, unfortunately, is the periductal infiltrating, which is your so-called Klatskin tumor or Hyler tumor, or it can go outside the bile ducts, and you typically have bilobar obstruction, and you have infiltrative soft tissue around the hilum, which is often delayed enhancement because of the desmoplastic component, and there's the counterpart of the growth histology of that same patient. So the reason they do badly is because they tend to grow deep to the bile duct wall, and they can have perineural invasion, even though they may not have vascular invasion, and which will result in recurrences often after resection. And that's part of the reason why typically these are not considered for transplantation as a treatment modality, because of the high risk of recurrence, and we'll talk about that a little more later. Another example of a mass-forming type, Dr. Roth already showed that, so I'm just going to go ahead and skip that. Essentially, these are intrahepatic types, most common. They're usually well circumscribed. They can have satellite nodules adjacent to it, but typically they're not multifocal throughout the liver, unlike metastases, so that may be a clue for you to distinguish them from mets. And also, these are generally having an unfavorable prognosis. As shown earlier, they have variable T2 signal depending on the amount of desmoplastic reaction and the fibrosis and water content. They often cause capsular retraction in the peripheral. And something important to realize is peripheral bile duct dilatation is not necessary to make a diagnosis of a peripheral cholangiocarcinoma, although it sounds kind of counterintuitive. So they may just present as a focal mass mimicking a metastases. And you can have overt vascular patterns at times, although the more common pattern is hypovascular with slow filling in kind of a peripheral to central pattern. They can be quite vascular, but they generally tend to hold on to the contrast. There are also certain biphenotypic tumors which have both HCC and CCA components, but I'm not going to get into that. But suffice to say that some tumors may be vascular than what you're used to seeing, so just keep that in mind. And this is the same example as a T2 showing, again, increased vascularity, but nice capsular retraction and the T2 signal as well. Note both these cases have no peripheral bile duct dilatation. These are both pathologically proven cholangiocarcinomas. And that's the reason why they show that delayed enhancement and the capsular retraction with all the pink stuff showing you this desmoplastic reaction of the spindle cells of the fibrosis. And this was the correct answer, where it's the intraductal growing type. Essentially, it's a intraluminal mass, and these typically do well because they have a superficial surface growth. They don't penetrate through the bile duct wall, and once you resect them and you clear the margins, you're probably okay. Unfortunately, this is extremely rare. This is the least common type of cholangiocarcinoma. So let's now move on to some of the differentials of cholangiocarcinoma. Once you've made a diagnosis, you got to think again and say to yourself, is that really a cholangiocarcinoma? And this is the part where you come in again. Which of these is a cholangiocarcinoma? So you got three examples. These are just MRCP radial images, and the options are 1A, 2B, 3C, or 4D, which is all of the above or none of the above, in case I'm trying to trick you with something else. So go ahead and start answering, please. I'm going to close the clock in 30 seconds. It doesn't matter if it's a wrong answer again, because this is kind of to make a point that some of these images are not enough to make a diagnosis by themselves. So go ahead and pick a side. It's anonymous totally. We don't know who's naming and who's playing, except the Maple Leafs are losing. So I'm going to just go ahead and get to the answer. And the correct answer is B. 12% of you got it correctly. And that's all right if most of you didn't get it, because you're not supposed to get the right answer on that question, because there's a point I'm trying to make here. Is that just MRCP pulse sequences are not enough to make a diagnosis of cholangiocarcinoma. It's always a comprehensive examination. So the very first case on your left, this is the situation there. These are actual TrueFISP images, actually, with showing you a T2 dark structure and bile duct obstruction. It's in the gallbladder neck. So this is obviously a case of Meridzi syndrome, where there's a stone in the cystic duct causing a common hepatic bile duct obstruction. Usually they cause mass effect, but when they're chronic, they can result in an inflammatory mass, and they can also erode into the common hepatic duct or the GI tract, and they can mimic a cholangiocarcinoma quite closely, as I showed earlier. And there's the MRCP image I showed earlier, where you can see an extrinsic indentation on the common hepatic duct and bile duct obstruction. So it mimics a cholangiocarcinoma quite closely, but when you look at the actual T2 images, the real answer comes out. This is the third example on the far right in that slide, where this is a coronal T2 weighted image showing you bilateral biliary dilatation, and then there's a T2 dark mass, which looks quite much like a Klatskin's tumor, where when you look at this patient's pancreas, you can see a classic rind around the pancreas, which is in keeping with IgG4 disease or autoimmune pancreatitis. And this is the MRCP image of that patient mimicking a cholangiocarcinoma or multifocal stricturing, and after steroids, it's completely resolved. So it's important to look at all structures in union when you're doing these kind of cases. And I don't think I need to go further on IgG4. You all know about it, that they have IgG4 elevations. They typically respond to steroids. They have a capsular rim. And more importantly, usually the pancreatic duct is not dilated in autoimmune pancreatitis. It's either normal or diminished in caliber because of the mass effect. Another question, this is one of my favorite cases where this patient was being treated for PSC and was not improving. And the question was, what's going on here? Does this patient have a cholangiocarcinoma or is it something else? All the previous MR examinations have been performed as just an MRCP with no GAD until we decided to do a full protocol here, and this is what we saw. So the real question here is, what is the diagnosis here? It's not PSC, and you have to make up your mind as to what the answer is here. And I'm missing some of the questions here. Okay, here are the questions. So you have sclerosing cholangitis, which I already told you it's not. So you have 5 options left, which is HIV, CHD cholangio, RPC or recurrent pyogenic cholangitis, E, portal idiopathy, and F, IgG4 or AIP. So again, if you can go ahead and vote, please. Okay, I'm going to give you another 10 seconds on this one. So here's the MRCP image, and this is a contrast kind of venous phase image showing something is missing out there. Okay, I think we'll just move ahead in the interest of time, and we'll walk through the case again. And the answer is E. About 1/5 of you got it right, and absolutely that's a tough diagnosis to make. And let's see what's happening here. So essentially portal biliopathy is where you have thrombosis of the portal vein and you have collateralization, either a cavernous transformation or there's a lot of pericholedochal plexuses which open up and can constrict the bile duct and actually cause ischemic strictures as well as fibrosis. And it can mimic a variety of conditions such as PSC or even cholangiocarcinoma. And the important clue here is the portal vein was thrombosed and there was a lot of collateral flow around the bile ducts resulting in an obstruction. Another example, you don't have to vote on this one. I'm just going to do a show and tell here. MRCP image showing segmental bile duct obstruction. The concern here is their left hepatic duct cholangio, and these are the contrast-enhanced images of the liver through that area, and you can see an infiltrative mass in the left lobe in segment 4, partially in segment 2. And then you can see a very peculiar appearance here where this is the portal vein and it's invading into the portal vein. So this is not a cholangiocarcinoma. This is an infiltrative pattern of HCC. So they can overlap in appearances. HCCs can result in bile duct obstruction. So every mass resulting in bile duct obstruction is not a cholangiocarcinoma. That's the point here. And the second point here is portal vein invasion is a sign basically of HCC. This is a study we did a few years ago where we looked at colorectal mets, and almost 20% of our patients with colorectal cancer had bile duct obstruction irrespective of size. And this is well documented in histology that they have a propensity to actually invade bile ducts. So if you have a solitary mass with bile duct dilatation, statistically keep in mind that it may be a colorectal met, and you might want to do a colonoscopy to exclude that before you just jump and say that this is a peripheral type of cholangiocarcinoma. Let's move on to staging, which is actually the most critical part as to why we image these patients once the diagnosis is confirmed. And it's important to remember in perspective that resection or transplantation in limited scenarios is the only effective treatment. And I have that in quotations there because it's a relative term. So the 5-year survival with surgery with a negative margin is about 10 to 30%, which is not great. But if you do nothing, these patients essentially will die within the next 6 months or a year, and the chances are almost zero of survival for 5 years. However, the surgical morbidity and mortality with cholangiocarcinoma resections is quite high. Almost a quarter of these patients will get significant morbidity even in high-end hepatobiliary centers, and almost 5% will actually die from the surgery. So it's important to realize that. There are essentially 3 staging systems, which are Bismuth, Blumgart, and TNM. Essentially, this is the historical staging system, which looks at only the extent along the bile ducts, and there's type 1, 2, 3A, and 4, and you can read about that in the books. I myself have a hard time remembering them. It's important to realize that this is an incomplete staging system because it has no account of vascular invasion, nodal status, and metastases, which are essentially required to make a decision for resectability. The more preferable classification, whether you use the term Bloomgard or not, is this classification system where you divide tumors into T1, 2s, and 3s, where T1s are essentially the bile duct confluence with or without unilateral extension to the second order ducts. And we mean by second order, we mean the right anterior and the right posterior on the right, and then the left lateral and the left medial segments on the left. So it's important to know that. A T2 tumor is essentially a T1 tumor, but you have either ipsilateral portal infiltration or you have ipsilateral portal or lobar atrophy, but those two are still resectable by traditional means. And essentially it's T3 where the line is drawn, just like any other tumor, where you have biliary confluence involvement and then you have bilateral second order involvement, or you have unilateral second order on one and contralateral portal vein or artery on the other side, or you have essentially involvement of the main hepatic artery or the main portal vein. So that makes it a traditionally unresectable cholangiocarcinoma. And so when you're looking at these cases, you want to have some kind of a checklist at the back of your head or a structure report, whatever helps you to go through these cases and say, what is the longitudinal extent of the tumor, meaning, unfortunately, this animation didn't work and it just blasted itself onto it. Essentially, you want to look at the extent of bile duct involvement longitudinally along the tree, both inferiorly as well as superiorly into the liver. You want to look at the radial spread, where it's spreading outwards through the wall, as to what kind of vessels are getting encased and narrowed. You want to look at lymph nodes, and you want to look at distant metastases. You want to give some comment about the liver volume in terms of, if you're not going to measure it, at least if you see a really small left lobe and you're going to plan a right hepatectomy, it's important to note that, or you can perform volumetrics before surgery as well. And then, of course, look for coexistent diseases. And do not forget those biliary, arterial, and portal vein anomalies, and your surgeons will really appreciate that when it's in the reports. So let's go through some very quick examples. I'm running out of time here. So this is like a T1 tumor where it's involving the confluence, and then it's involving the right hepatic duct. And there's a kind of extension to the right anterior and posterior, but it's not affecting the contralateral side, so a right hepatectomy could take care of this. This is an example of a T2 tumor where it's involving the left hepatic duct, where there's atrophy of the lobe as well, and therefore it becomes a T2, but it could still be resected by a formal left hepatectomy. Here's an example of a traditionally unresectable T3 tumor where you have lobar atrophy of the left side, and then on the right side you have portal vein encasement as well as hepatic parenchymal invasion. So this would be quite challenging to resect directly and would be considered unresectable in most centers. I was going to ask this as a question, but I think I'm going to skip it. I'm just going to walk through it. This is the extent of biliary involvement in that particular case, where you have involvement of the CHD, right hepatic duct, right anterior duct, right posterior duct, and left hepatic duct. So it's essentially a T1/T2 tumor. There is no vascular encasement. There are no nodes. The future liver remnant, which is the liver volume being left over after a formal resection, will be about more than 25%, and then there are no Mets, and therefore this is a resectable tumor. And this is the pathway you would go around when you're trying to stage all these cholangiocarcinomas. And the correct answer was yes, it's resectable. Some more examples. Here's a case where you have, again, involvement of the common hepatic duct, the right hepatic duct, and the left hepatic duct. And looks kind of, there's a peripherally infiltrative mass. It looks all right there. However, there's main portal vein encasement as well here. So this is clearly unresectable. Another example where you have an infiltrative mass, again, in the left lobe as well as the hilum. So it's still restricted to the left lobe and could be resectable. But on diffusion-weighted images, we identified some target lesions on the other side, which didn't look really good. And following contrast, you can see some nodules which are enhancing within the liver. And on the delayed hepatobiliary phase, they were actually hypointense, suggesting they were actually metastatic deposits on the other side of multifocal disease, which is quite rare. But we made the call, and the patient was not resected. I'm not sure what's going on there, but I guess it's a clue that I got to wrap up. The last 2 minutes, I'm going to touch about surveillance of high-risk groups. Essentially, it's PSC, PSC, and PSC. Occasionally, you have Caroli's disease and choledochal cysts, which are the other surveillance types. It's really challenging to make a diagnosis of cholangio in the setting of PSC, although these patients are at increased risk. There's about a 1% annual incidence, and it's very difficult to make a call on a single MR examination. You have to look at multiple serial MRs as well as some markers such as CA19-9, which, when there are about 100 units, that's suspicious that there is a cholangiocarcinoma. But what are the tips actually on MR that there is a cholangiocarcinoma is something like a short interval appearance of a new area of bile duct dilatation. So generally PSC is a very slow progressing indolent disease, and it takes years for us to realize that there's actually a change in the degree of bile duct dilatation. So if you start seeing those changes rapidly, in the sense every 3 or 6 months, that's too fast for PSC, and there's likely a dominant stricture or cholangiocarcinoma coming in. Also, generally, PSC is more of a uniform disorder, and if you have kind of disproportionate dilatation in a segment or an area, that should pick you off that there's likely a cholangiocarcinoma coming up. Essentially, by the time you have a mass adjacent to a lesion, it's kind of late. You already have missed that lesion on the previous surveillance examination. So here's an example of that. You have July 2006, this patient was not doing well, was brought back usually they undergo annual surveillance, but because of the LFTs being out of control, he was brought back with a suspicion of cholangio, and of course, you can see this new area of dilatation in 6 months, which is out of keeping with the natural progression of PSC. And indeed, there was a mass within the periphery of the liver, which was resulting in that. So this was a classic cholangiocarcinoma superimposed on PSC, but these can be quite challenging to call when you don't see a peripheral mass. Choledochal cysts, nodules within choledochal cysts should be a tip-off that there's a papillary-type cholangiocarcinoma coming in. This is a CT in July 2008 where we did pick up that nodule. However, a patient decided not to undergo surgery and was on surveillance, and of course it grew over time to that size, and then I think patient finally consented to undergo surgery, and it was a papillary cholangiocarcinoma. So with that, I'd like to end in saying that MR plays a crucial role in the diagnosis, staging, and surveillance of cholangiocarcinoma. High-quality imaging, particularly those MRCP sequences, are key to a protocol. It has to be comprehensive with contrast. Be aware of all those mimics, because there's a lot of entities which can mimic cholangiocarcinomas. Evaluation of resectability, you have to go down that pathway, either in form of a structured report or just having those points at the back of your mind when you're trying to stage these tumors. And finally, cholangiocarcinoma is still challenging to diagnose and delineate in PSC. Thank you very much.
Thank you, Kartik. That was an excellent discussion of cholangiocarcinoma. I don't know how to show the score here, but I believe there's the individual scores. My recollection, though, I think the Flyers won, which is probably not a harbinger of the future. But I want to thank the committee for inviting us to be here today, and thank the audience for their participation. And we'll be up front hanging out if you have any questions or want to chat. Thank you very much.